I think I was definitely the first autonomous reporting radiographer for cardiac MRI, yes.
If we need to strike the right balance, do you think at the moment patient preparation is still the crucial bit, or the fact that there are new things like AI, compressed sensing, which are cutting down, the breath holding time, for instance? Would you be more focused on that part?
Don't get me wrong, you will miss things. If one of the nature of any reporting is you will occasionally miss something, and it's horrible.
Is there a credentialing kind of process, or what gives you a credential to actually be a reporting radiographer?
I would vet it, protocol it, book it, scan the patient, then report it within 24 hours.
You essentially do everything. What do you think was actually the need for them to say, actually, we need a radiographer to come and help us and report some cardiac MRI scan?
How do your now colleagues, let's say radiologists, cardiologists, perceive that role that you have?
When you learn cardiac MRI, if you're told by 4 different people 4 different ways of doing something, it's already complicated, and that makes it worse.
We don't see AI coming in our lives, but our lives will be completely different in 5 years because of AI.
You will then have a transferable certification, essentially, a quantifiable certification that you can then put on the table and say, I am at this level for reporting. I think that communication and patient preparation is the most important thing in cardiac MRI.
I would say in most countries, if you go there and you say to anyone, do you know actually that radiographers can report a scan? That is the pathway for the reporting radiographer. They will tell you, are you crazy? Radiographer reporting scans. Is that really a thing? And we actually are here today to testify that it's possible. There is this career pathway, and we have here Kevin, which is going to help us to understand a little bit more how is the life of a reporting radiographer. Obviously, you do also something else in the background, so you might help us to understand how this fit your current new role. And but first thing I would say, how did you end up being a reporting radiographer? Because not only that, you actually report cardiac MRI, which is even more advanced and specific. Tell us a little bit more about this.
So, I mean, the role of the reporting radiographer is fairly well established in the UK and has been for more than a decade, I would have thought, absolutely. But it started very much along chest x-rays. It started on very simple stuff and then moved on to CT. We do have some MR reporting radiographers, but the role of the cardiac reporting radiographer just wasn't there. It's a complex exam. You guys will know if you've done cardiac MR that it is. Every patient's different. The anatomy changes all the time. It's not like doing a brain or a knee where you will line it up and it looks the same. You have the same. You do have landmarks. You have the same things that you're looking for. Like you have your, if you remember back when you were started as a radiographer, you have your 10-point checks for your chest x-ray to make sure you've got everything. It's a similar process, but within that, it's just a little bit more complex and it's a little bit more involved, I guess, with it. Because you've not only got the anatomy that you're looking at, you have extra cardiac stuff as well, which is something that...
And correct me if you were the very first
I believe so,
MRI reporting radiographer, at least that we are aware.
Certainly so the first autonomous...
This is quite an achievement, shall we say that?
Well, I think I was definitely the first autonomous reporting radiographer for cardiac MRI, yes.
Do you think is
so I sign off all my own
thing in UK? Because as Julian was saying, for example, in Portugal, Italy, we don't have reporting radiographers. Why in UK you think that's
I think a thing? A lot of it was born out of necessity. So we have a shortage of radiologists, and they are time poor, as most consultants are. And certainly when it started off with chest x-ray interpretation, for example, it was a question of these are the simplest things that we do, but they're also very time consuming. So how can we make that accessible to others? How can we free up some of our time to do the more complex stuff? And I think that's what happened. I think that's where it was born from. Okay. It was, we had a profession in radiography that were looking for advanced practice along with the SOR guidelines of advanced practice. And that was a way of doing it. It was sort of discussion with radiologists, with the clinicians about where their pressures were, and the time pressures are one of the biggest things. So then you look at what parts of their role can we assist with, and that's how it started. I believe it started as a.
Is this what happened for you?
Kind of, yeah. It was. So I started to report Herceptin scans. So certain breast cancers and upper GI cancers will be sensitive to Herceptin as part of their drug therapy, part of their chemotherapy. Herceptin can cause cardiotoxicity, and one of the first signs of cardiotoxicity with this is a reduction in ejection fraction. So basically, one of the first things you do with any cardiac MRI is you will contour. It always used to be done by hand. So you draw circles.
Yeah.
The auto-contouring exists now, but you still need checking. So you do your contouring, you'd get your volumes, you'd get your stroke volume, you'd get your end systolic, end diastolic volume, and then you get an ejection fraction. So it's fairly straightforward stuff. You're not really doing much other than contouring, getting your stroke volumes, getting your ejection fraction. You would do a baseline before they started on their drug therapy, and then you do surveillance scans through. And part of what you did was you would comment on whether or not the ejection fraction had dropped. There are levels, as there are with anything. There are tolerances, there's quantitative aspects to it. So you will, if it drops below 55%, then it goes into sort of the mildly impaired area, and then below 45 mildly, and then sort of moderately, and then below 35 it becomes sort of severely. But then that's progressed, so we now do some strain analysis as part of that as well, because strain analysis has been shown to be more sensitive to first signs of cardiotoxicity. So that's something that's moved into. So it was. We do a lot of them. Where I worked in Nottingham, we did a lot of these Herceptin scans, probably 15 a week.
But what do you think was actually the need for them to say, actually, we need a radiographer to come and help us and report some cardiac MRI scan? What was the key factor that kind of like...
So I think it was kind of a happy coming together. So I was in the role as a sort of specialist cardiac MRI radiographer. I had a close relationship with the consultants and working with them, and we had a discussion about, what's the part of your role that takes up your most time, that you struggle with, and it was these Herceptin scans. We did 10 to 15 a week. They don't take an awful long time to report, but it's still time out of their day to do it. And it's like, well, it started off with the discussion of maybe a radiographer could do the contouring and check the contouring.
Okay. You start doing the basics first.
To do the basics. So you start to then familiarize yourself with the post-processing software and the volumetrics and what you actually need. And then we had a discussion. And I think because the established paths for reporting are radiology based, and cardiac MRI often falls between the two stools. So it's between cardiology and radiology a lot of the time. And my mentor, Dr. Sosin in Nottingham, he was of the opinion, well, cardiac physiologists perform and report their own scans because they're expert at what they do. You're expert at what you do. Kind of makes sense.
Right?
Why wouldn't you do it? So we looked at formal pathways to do it. Now, again, it should be pointed out that when I started autonomously reporting, it was March 2020. I don't know if you remember March 2020.
It was a very specific
but
period.
It was a very specific time in history. So a lot of the cardiologists as well were being pulled out of their imaging list. We cancelled a lot of outpatients for cardiac MR.
Yeah.
But we didn't want to cancel the oncology patients, obviously, because they were in the middle of a care pathway. But the consultants weren't around. So it was almost like a sort of a battlefield promotion in some ways, in that I could physically do it. We'd done the legwork before that, so we did 100 double reporting before that, and it just it coincided with like I say, March 2020 when the world shut down.
Perfect storm for you, right?
It was
to land
in some ways,
position. Yeah. Do you think that perfect storm is replicable for other people that would like to follow the same path?
So what we did was establish a pathway. We wrote what guidelines we could do, because there is no educational or formal educational pathway for reporting for cardiac MRI. There are for other modalities and for
Can
other
we
ways
touch
of doing
base
it.
on that as
Yeah,
well?
of course.
What do you think radiographers mostly report nowadays, like in the United Kingdom? Is there anything? You mentioned chest X-ray, which I guess is like the most common possibly.
Chest
Absolutely,
orbits,
yeah.
stuff like that.
Is there
plain
anything
film
else that
X-ray
you,
is the
you
main.
kind of like, you're pretty sure that there are other areas that
Absolutely. So certainly plain film X-ray is the main
Yeah.
part of it. Now within CT we had sort of nodules, lung nodes, reporting radiographers at Nottingham. Within MR it tends to be neuro, so lumbar spines, knees,
needs as well.
and some there is some IAM reporters as well. So
I've
very
seen that, yeah.
very
Yeah.
specific brain scans rather than. But again, because you report an IAM, if you have a sequence that includes the whole brain, you have to report that as well. Whatever's acquired has to be reported.
This is something I always ask myself. What is going to happen if that, as you mentioned, if you kind of like fall a little bit short from your scope of practice? I mean, let's say that someone like other flare, like a 3D space flare or whatever it is, and whole brain, and you suddenly you need to, to report, you probably spot like an MS lesion, kind of like that, but something that you're not specifically, kind of like, you're not specifically comfortable, you're not specifically asked to report. So how do you do it? Do you kind of like pass it to like a radiologist? Or?
Absolutely. It's that sort of paradigm of phone a friend, and that's like exactly what you do. You have got to be very aware of your scope of practice, and you have got to know what you don't know to work safely. And certainly within my practice, if I see any extra cardiac findings, so again, like I say, a lot of the patients that I report are cancer patients. So that there's, you do see metastatic deposits, you do see other things within the scope of it, because with cardiac MRI you do an axial localizer that covers the whole the whole thorax, and that's where you will see things. But if I see something, then I have radiologists I will email and say, can you have a look at this, please? There's something on this, and then they either are referred for further imaging or something else.
For example, imagine a new radiographer starting. You do that because you have your ethical way of working and you have your morals, whatever. But some radiographers might not feel like, I don't want to pass this because they will think I can't do it, and this is a brand new branch.
I think that's a very dangerous
Do you have that
attitude.
fear that
I think
someone
you
might
have
do
got
that?
to park your ego when you go into reporting, because it is somebody's life essentially that you're dealing with. Now, don't get me wrong, you will miss things. If one of the nature of any reporting is you will occasionally miss something, and it's horrible. The first time I missed something, it's you beat yourself up about it. You hate that you've missed it. You have a pattern, you have a process. Like I say, like we talked about with the chest X-ray evaluation, it's the same thing. So you'll look at the lung fields going up and down on both sides, and then you'll look at the soft tissue. You'll look, and you have this process that you'll follow. You'll look at the liver, but you can't have an ego about, I should be able to do this. You have got to accept that someone is better. Someone knows.
Challenging yourself.
It's not about that. It's not
right
about.
thing.
It's not about looking silly or being. He's just a radiographer. He doesn't know what he's doing. It's not that at all. And it comes the other way as well. I have radiologists that will sometimes email me and say, "Can you have a look at this? Have you seen something on the bottom of a?"
But particularly because I was thinking liability plays a key role. So I think if you kind of like don't want to be ashamed and pass it to someone else, at the same time you need to think about it. Okay, if I actually expose myself, I might be liable. So I think now I don't want to go too much in detail, but I guess you pay for an insurance or something like that, right?
You have to have a liability.
So you need to have like something that backs you up a little bit.
And that's it. And that's why when we went through the training process, so because there was no formal pathway, we went through a competency-based training program. That's why we were so robust about it. That's why we went through both cardiology and radiology governance for it. Because phrase that I use is, if you're going to put your head above the parapet, you're going to get shot at, and you'd better make damn sure that you're bulletproof if you do it. And that's, so you have to make sure that you have these processes in place. So we had someone that came and trained after me that while I was still worked in Nottingham. We have and Nottingham has someone that's just about to undergo that process now again. So it's about having clinicians that are supportive. So the team that I worked with in Nottingham, both radiologists and cardiologists, were incredibly supportive. So like say, I'd missed a metastatic. Well, what happened was I'd seen a metastatic deposit on a scan, but it had been on the previous one because it was a surveillance scan, and I just hadn't seen it the first time. I just hadn't seen it. And every single one of the radiologists came and said, if you're not missing things, you're not doing enough work. Is kind of the way it's at. And it was kind of the way you react to it. That you're going to have adversity, you're going to have things that go
it's
wrong,
all about how you
and it's
react
how
to
you
it.
react and what you do to. What processes you try and put into place to make sure it doesn't happen
It's a learning
again.
process. It's a learning
It
process.
is, but it's still horrible when it happens. But you do your very best to make sure it doesn't.
Just to be clear, this is NHS based, right? Never private.
This is
And
NHS
is
based.
there a credentialing kind of process, or what gives you a credential to actually be a reporting radiographer?
So it's multi-leveled. So if you want to report plain film, then there are established pathways, educational pathways that you can do. You can do reporting, masters and postgraduate certification for that. You can do it within MRI as well. You can do an MRI postgraduate in reporting.
I think there are a couple of pathways. I think I've seen the advertising,
And I think Bradford as well. Forgive me if it's not Bradford, but I think it is. I have a colleague who reports. Rachel reports aortas,
that's good.
and she did a bespoke module through the reporting framework at Bradford. But again, it's about you have to have the clinical support to do it. You have to have. So
That's a fact,
Mike Sozen, who was my mentor, who came out to bat for me when
It's
needed
a big
be.
trust component there, basically.
Absolutely.
The person that is supervising you needs to trust you,
Yes.
almost not blindly, but almost to a level that allows you to do your job by yourself.
To a certain extent, but they also, will ride you quite hard as well as has to be, because
As they
again,
should, right?
because again, if you're doing something that's pioneering, something that's then you have it's this idea of being bulletproof as well. You have to almost prove that you're better than if a clinician or a physician was doing it, because you have to make sure that people can't. Because the first mistake that happens, or the first thing that you get wrong, it'll be radiographers can't do that.
Yeah, exactly.
So you have to try and.
You're always fighting a wall, basically.
Yeah.
You are. You sort of.
Very true.
You create these new ways of working, but they're not always accepted. So interestingly, just last week, I went on a drink with Mike, and the EACVI are now looking at allowing radiographers to do their level 2 examination. So all physicians who want to report cardiac MRI have to do the level 2 examination, and if they want to run a service, they have to do level 3. Up until, still currently, you have to be a physician to do that. You're not allowed to do it if you're an allied health professional or anyone else. And this is Europe-wide. We have been in discussion with them, and Mike's been central to this. We've been in discussion with them for probably 4 or 5 years, and they're now looking at letting radiographers do this examination. What that will provide is a level of certification that is then transferable.
Wow, that's great.
So you can then use that. You can take it and say, well, I have got the same level.
Yeah, you have a sort of
My peers.
You can demonstrate.
There was a lot of conversation involved about whether or not this would be a different type of exam for radiographers, that it would be a radiographer exam rather than, but I, in particular, and Mike as well, we were very adamant that it shouldn't be. If we report in the same scans, the level of training and the level of examination has to be the same, in my view.
Yeah, I
Do you think
agree.
as a radiographer you bring a unique view to that report because you also scan those patients?
Lovely question.
Absolutely. And, I had a couple of instances that were really, so I would get a referral through, I would vet it, protocol it, book it, scan the patient, then report it within 24
You
hours.
essentially do everything.
So it was
I guess I'm cleaning at home if you will.
Yeah, my wife would agree with that. But I think, so, you could have that within 24-hour period. You could, from referral to published report within 24 hours, and I would do every aspect of that. And that's quite nice. It's quite nice to be able to do that. Obviously, the more senior you become, certainly within the NHS, the less clinical you are. Almost by definition, you tend to only become become clinical when things go wrong. People only come and get you when something, either someone's hard to cannulate or the scan's gone wrong or the scanner's not working. And
I think we've all been there.
Exactly. But that's part of it. But yeah, so I think you do bring in you have perhaps a different perspective on things as a radiographer. I think there are dangers, if dangers is the right word, for reporting radiographers within this. And again, it's something that we've discussed, I've spoken about a lot, is that you have this very specific skill set. So within cardiology, for example, if you're doing cardiac MRI, you can report cardiac MRI. What I can't report is echo. What I can't report is cardiac CT. I haven't done those things.
Yeah.
I'm not a cardiologist. I don't have that broad umbrella of cardiology knowledge that a cardiologist has. So if I'm seeing something, I then have to, so if I'm, for example, if there's a conductive issue, if there's a left bundle branch block or something, I can see that, I can recognize it, but I have then got to be aware of the point in the pathway, the patient pathway that this arises and how it extends beyond that and what my scope is within that.
Yeah.
So you find yourself, you're almost raised quite high on a plinth almost, but like half a step in either direction and you can fall. Whereas from a clinician, a physician's point of view, they have a more sort of bell curve to it. So they've got a wider range of knowledge over more areas. And I think that's one thing that you can get if you're reporting as a radiographer. You can become quite isolated quite quickly.
Yeah.
Because you are at a pinnacle, but you're only at one pinnacle.
Yeah.
Yeah.
And you have to be very aware of that.
I have a question for you about this.
Sure.
Ken, because you mentioned the word danger. There are some dangers potentially. And I can see what they might be, but I want to take like a comment that I have from a dear colleague at times. When I got introduced to the world of reporting, when I came to the UK, I wasn't aware. And someone told me, yeah, well, there are colleagues that they report scans. And he clearly told me, yeah, but what's the deal? I mean, they take all their responsibilities. They do this, very specific study. And then they might end up being band 7, which you can also be by being like an advanced radiographer. While radiologists, they make like very good money. And we know that. Perhaps performing the same tasks or like similar tasks. So that's the deal. Do you think is that like financially, is it kind of like does it kind of like add value? Kind of like follow this type of pathway?
Is it attractive actually?
Is it something attractive, you think? Or is it like, yeah, actually, I need to confirm that if you want to be a reporting radiographer or whatever, you might need to follow the same bands, the same grades that other radiographers might follow. Because to me, it seems there is no specific grade at the moment for a reporting radiographer.
There is.
There is.
So
okay.
You're a band 7. If you
You're
report,
band 7.
you are
Yeah.
a band, and you have to report for multiple. So, for example, we mentioned before we started about intraorbital reporting for metallic foreign bodies. That doesn't equate to a band 7 because it's just a very specific.
Yeah, back then when I did
non-horizontal.
that was mainly regarding MRI safety. So we wanted to make sure we could scan that patient.
Exactly.
So we did the scan and we would report it straight away. And that's
but
it.
any reporting radiographer should be band 7 at least. The way that the bands and the agenda for change structure is that to move beyond that. So I was working as an 8A within Nottingham because I was running the cardiac service. Yeah. The cardiac MRI service, and with the other aspects of my role. So I was doing a lot of presenting around the country, around the world, a lot of teaching, a lot of that kind of thing, sort of fulfilling a lot of the criteria for consultant sort of radiographer, and that was kind of where I was heading. But then there was some internal politics that I don't really want to go into. But yeah, it's. I think if you are looking for a financial reward or you want to move up a band, that certainly reporting can be an easy way of doing it, in inverted commas, depending on what you're doing. But reporting cardiac MRI is not an easy way to a band 7. It's a very difficult way to get to a band 7.
It's a very niche
It's very
area
niche.
of what we do.
Yeah, I mean, joked about this for a few years, that I became more and more niche. I started off as a radiographer, then I went into MRI, then I went to cardiac MRI, then I went to reporting. So I was just painting myself into a corner, making myself essentially almost unemployable by anyone because, I'm in this very, very tiny group of cardiac MRI reporting radiographers. I think there's sort of maybe three of us.
I think
around.
you're very humble, because I think you mentioned something. Well, we can also mention your current role, which is for Philips as cardiac expert. Yeah. But you also told me, how many scans do you report every year?
About 600 a year.
600.
Yeah. Since I left Nottingham in August 2023, I've reported over 1,000 scans.
How do your now colleagues, let's say radiologists, cardiologists, perceive that role that you have? Let's say you go to a new place, or you've been in a new hospital when you left Nottingham. How did they perceive you as a reporting radiographer? Did they look at you and say, what is he doing? Or they actually were very supportive? How is that environment?
So I only report still for Nottingham.
Still for them.
So because partly, as I said before, I think because we did a competency-based training, and we went through local governance, we went through Nottingham.
I was going to ask you about governance, so there you go. Yeah, perfect.
So I think because it was very specific to Nottingham, that it's non-transferable, and this is why what the 𝐂𝐥𝐢𝐴 and 𝐂𝐴 are considering is a bit of a game changer from a radiographer's perspective, because then you'll then have a transferable certification, essentially a quantifiable certification that you can then put on the table and say, I am at this level for reporting. It's something that is also the CMR are looking out for cardiac radiographers, cardiac MRI radiographers in general, and they have released sort of their level, their 3-level training schedule essentially, and logbooks. And that's something that I ran the first Philips cardiac MRI course in March in Nottingham. We used that SCMR framework.
Yeah, I saw that.
For the first 2 parts. So it was a 2-day. So we did sort of essentially a foundation and intermediate day. I'm running another one on the 12th and 13th of November. The same. It'll be in Nottingham again, but there'll be live sessions in that, and that will be essentially an intermediate and advanced day. So we'll be looking at congenital, we'll be looking at pediatric scanning, we'll be looking at infiltration, and we'll also have live scanning sessions as well. So that sort of idea that these courses that use this framework will then provide a level of certification for radiographers to say, I am a level 3 cardiac MRI.
Yeah, this is something actually we're looking after very closely as well, because we have a cardiac course within Everything MRI.
So direct competitors.
It's always good competition.
Yeah, of course.
But we're looking into this framework as well, something that we're very interested as well.
Yeah.
And because I think we need actually this type of advanced skills.
I think it gives people... It's very difficult because, the way you would define... It's something that came up in our conversation about the reporting side of it is, how do you define a experienced CMR radiographer? Because the idea was, we'll say, if you've been doing it for 5 years, but you know what it's like. You can have been performing cardiac MRI for 5 years, but you might have only done 20.
I'm an example of that. I've been doing cardiac for 5 or 6 years, and I don't consider myself an experienced cardiac radiographer, because I was doing basic scans, sometimes some stress, some kind of hypertension scans, but they were never, for example, congenital. They were never very routine at our place. I would do one now, another one in 2 or 3 months, another one.
Exactly.
So I don't consider myself an experienced cardiac radiographer. I know how to do the basics, but I'm not an experienced.
But that's why a time frame isn't a good representation of experience.
Yeah,
so it is about, and so that's hopefully what this sort of quantification, this level quantification, it's about numbers. It's about, because people do learn at different paces and in different ways. So I think that having a structured level of qualification that's either endorsed by, so another one of my roles is I'm chair of the BSCMR's Radiographer Working Group, and so I sit on the board at the BSCMR as well. And one of the things that we're talking about at the moment is trying to do something similar and trying to get some sort of endorsement from the BSCMR along the lines of what the SCMR have produced, to give radiographers something that they can use as a framework and to provide evidence so they can say, well, actually, this is what I've done. This is my logbook. These are the exams that I've done. This is the training that I've done. These are the courses that I've done. I also do because I do a level 1 course for SPRs in Nottingham with one of my colleagues, Dr. 𝐬𝐥𝐢𝐿, and we're running that again in July. But that's for local SPRs, cardiology SPRs, to come and get their numbers.
Building a portfolio, basically.
Yeah, exactly. So it's numbers of cases.
Which
It's
at the end was
getting
the
them
idea
through.
that brought us to create that cardiac course.
Absolutely.
People asking for more and more skills,
Yeah.
and that's why we try to get a cardiologist all together. Cardiac, we got Filippo, cardiac MRI radiographer, because I think you need radiographers to kind of like transfer their skills. You cannot have a course set only by cardiologists or radiologists. You need to have someone relatable, someone that will tell
And
you
that's
this
why we have so the live scanning sessions are
that's so important.
so
I think that's
essentially
the key.
what
That's
we
the key
did
of it.
we dialed into the live session at Nottingham City Hospital where they were running a session, and we had the workspace open, and then we dialed in, and then we had a Teams call with the radiographer as well. So we performed the scan, and we essentially hot reported it as part of the session.
That's great.
And so we went through, we discussed it, and we looked at things, sequences, how to plan
So you were
them.
scanning and reporting
We
kind
were
of at the same time.
at the same time. So we
Makes
were doing
sense,
it, and we were sort of. So I was running the session. We had cardiologists in there as well, and we were just having the discussion, having the debate, and including people in it. And what that does, from a radiographer's perspective, is it raises awareness of what the report, how the report is formed, how it's framed, how it's built, and what elements of image evaluation are important. I mean, one of the things I used to do when I ran the service in Nottingham was I would have the new radiographers. They'd come to me for 4 weeks, Monday to Friday, 9 to 5, and do, because we did cardiac Monday to Friday, 9 to 5, on our Ingenia, and I would sit with them and do reporting sessions with them, do a couple of reporting sessions. So once they've done that,
so it's like that you're a soprano also to share your skills, because
absolutely.
I can imagine you want to also keep your own status, like of like a.
The status will always be there.
It's not really something that interests me, that aspect of it.
This is supposed to be the attitude.
This is exactly how it should be. I've always shared documentation. So Filippo, I've shared all of my training documents and everything with it, and I have no issue with that. I think it's about improving the profession and improving the landscape. It's not about personal achievement or personal gain.
It's about raising the community as a whole.
Exactly, and you sort of you're providing extra layers of evidence and extra layers of resources for people to hopefully not make the same mistakes that you make. I mean, when you're the first person to do something, you make an awful lot of mistakes, and you do things. So an example of that would be when I first started, we had a team of 9 reporters at Nottingham, and I would get them all to check my reports, and they'd all sign. But every single one of them does it differently. I mean, it's an old adage that if you want 4 different opinions, ask 3 cardiologists, because the first one will disagree with themselves, so not as to look like they're agreeing with someone. So you found I was writing a report with the person that was going to check it in mind, because they had different things that they wanted and different things they wanted to see in the report. And it was impossible. When you learn cardiac MRI, if you're told by 4 different people, 4 different ways of doing something, it's already complicated, and that makes it worse. So we brought it down to 1. So it was just Mike and I that did it. And the same thing with teaching. I'm a big believer is that you teach the teachers how to do it, and so when they teach, they're teaching as if you're doing it. So you don't get those conflicting viewpoints. You don't get that sort of, I do it like this. I always used to say, if someone else tells you to do something, tell you different to how I tell you to do it, that's absolutely fine. But they're wrong. Don't do it. Because, and it's not that it's not arrogance.
Exactly.
It's just this question of, everything I've done is fact checked. Everything I've done is based on evidence. It's all evidence based. And it doesn't mean to say that things don't change, because they do. We change protocols all the time. But as soon as someone tells you to do something different, just say, that's not the way Kevin's told me to do it. That's not the way we're doing it this time. And then we can have a discussion. It may be that we change. They may have a better way of doing it, but at that point, they're wrong. until it's proven right, they're wrong. If you see what I mean.
There's a lot of. It's a question. Do you think there's a lot of imposter syndrome?
Oh God,
with your role as a
absolutely.
as a reporting radiographer?
Endlessly. I have that almost every day.
That's something that I deal with quite often as well in everything that we do in Everything MRI. I don't know if Julian has it, but I have that imposter syndrome. And Julian knows when I go to present, I'm always, I'm so nervous. I don't know this, I don't know. And then it actually goes well because you have the experience and the knowledge. But I can imagine being in that position with so much responsibility already in a scan that is not easy to do, let alone to report, that you might feel that. So here and there.
Almost by default, I've become known as an expert in cardiac MRI. Now, partly is just because I've been doing it for a long time. And I've presented at conferences and things. And I learn something new. Every time I go on site, which I do, I learn something new every single time I do it. And the amount of people that say to me, this will be too basic for you. And you're like, no, basic's good. There's always something new. There's always a new way of learning. So it's not, when I said I'm right, it was more about the sort of the consistency of teaching rather than saying I'm always right. But absolutely, every time I go to a conference, every time I stand up and talk, I think, why on earth would anyone want to listen to what I have to say?
It's good that I don't feel alone anymore.
Why?
No, don't do that.
What gives me the right to stand up here and tell you what to do?
It's a very common thing when you go on a stage, but I was more interested when you, in your room, reporting that scan by yourself. Do you feel that self-doubt sometimes or not?
I used to, not so much now. I've been doing it for a while now, so I think I have that confidence in my ability. Again, it's not to say that there aren't still errors and aren't still mistakes that you make, but you hopefully make less of them as you become more experienced and you are more aware of them and you spot them a little bit earlier. I think it is something that when people start, especially with cardiac MRI, I think the extra cardiac findings are difficult for people. And sort of cardiomyopathies can be quite difficult to interpret. So I don't do any contrast interpretation at the moment. That was what we were heading to next, but I moved on. And it's where I think I do have a colleague in Grantham who's starting to do stress reporting and contrast reporting.
Wow.
Is that something you will pursue eventually?
It's something, because I'm not clinical now, I don't know I don't know. I think I would be supported. Philips have been very supportive they're very happy for me to carry on reporting. I do it in sort of my own time, but they're happy for me to promote that aspect of it. They're happy for me to come and talk to you guys, for example. It's a very supportive atmosphere within Philips.
That's good.
For my role, because as I say, it was almost a bespoke role, and it's evolving still, because there was no one that did this before me, so therefore again I'm making all the mistakes, and I'm
that's good
I'm
for
doing
you and
everything
for Philips
and
as
for
well,
people to come
because
afterwards,
they have that pathway now laid out because you're doing those mistakes.
So this is it. A lot of what I do and a lot of what I'm trying to do and a lot of what I talk about is this idea of legacy and this idea of inclusion. And again, to come back to this idea of the imaging team, to me that's absolutely at the cornerstone of what we do. And that team isn't just the radiographer, it's the physician, it's the clinical application specialist, it's the imaging assistants, it's the booking team, it's everyone that plays a role in that or has a part in that scan, because we're all there for the same reason. We're there for the patient that's in the scanner, and it's about improving the patient experience. It's about helping them to help you get the best possible diagnostic
Correct
images.
me if I'm wrong. Sorry, Julian, I know you want to ask something. What you're mentioning is the imaging team. You're moving away from the multidisciplinary team to one team that does one thing, which is basically treat cardiac patients. Is that the concept?
No, not necessarily. No, I think that imaging team will change depending on what you're doing, but I think it's about having an awareness of your role and the awareness of other people's role. Yeah.
Okay.
And also that sort of communication, that interaction with the imaging assistants, with the booking team. If the booking team know what they're doing, how, if you can give them the tools, if you can give them the knowledge to help with their booking, then the bookings are more efficient.
How often we complain about the booking
Yeah.
team. Oh, damn, that booking team again.
But
I'm going to go home late
such
tonight.
a vital part of the process,
is.
and they're
It is.
often
It's such
forgotten
an
about.
important part, yeah.
And they're often
and I
forgotten
feel
about
most of the time
and marginalised.
they make mistakes because they are not trained enough. They
Yeah.
don't know
Or
what's
they've been
happening.
told before to do
Yeah,
their way. and
exactly.
That
Yeah,
happens quite
exactly.
often.
And yeah,
So again, part of what I used to do every day was go and talk to the booking team. Spend some time with them, build a relationship
show them
with
around,
them,
show
and
them
just
like
talk to
the
them.
actual process of scanning and everything.
So then they know a little bit more about when patients arrive late or just how to deal with that first point of call. Because often they're the first point of contact within the department is the receptionist.
Exactly.
And if they have
And the
no
vetting
idea,
can start there too,
yeah.
most of the
So
time.
that's it. So you can have a patient can have a negative experience because their first interaction was a poor one. So ultimately, again, a lot of what I talk about is this idea of putting the patient at the center of everything we do.
Yeah.
And I know it's a bit of a cliche and everyone says it, but I think
Well, but it's a
you
cliche
have
for
to
a
put
reason,
it to
right?
practice. Yeah. You have to put it into practice. It's not just about saying it. It's about, so in my role with Philips at the moment, a lot of what I do is sequence optimization, protocol optimization. It's helping the radiographers to deal with arrhythmia, to deal with poor breath holders. And a big part of that conversation is, well, you talk to your patient. It's again, what we were saying earlier, is that you have that initial conversation with your patient and you make an assessment. How well are they going to be able to breath hold? Are they going to be able to do 10-second breath holds? Are they going to be able to do 50 10-second breath holds through the course of this exam? Have they got 5 breath holds in them? If they do, where do I want those 5 breath holds to be? And you only get that by talking to the patient.
them. You
and
have those
communicating.
emotional cues and you have the body language and all
I mean,
that.
you have a whole wealth of clinical information
yeah.
as well, which you can use from previous scans, from other things, and that all parts builds up these layers of information. But then, if you're aware of how the images are going to be interpreted, how the report's going to be framed, and how it's going to be built, then you're better able to make those clinical decisions when you're performing the scan and when you're acquiring
it goes back
the
to the
sequences.
training that you're talking about. Even if those radiographers don't go towards the reporting field, they still know that's important when they acquiring those images.
Can I say
Exactly.
something about this, Kevin? Because from your current role, obviously you see all the new frontiers in cardiac MRI, compressed sensing, all the new features on AI, obviously, which is coming. Do you feel if we need to strike the right balance, do you think at the moment patient preparation is still the crucial bit, or the fact that there are new things like AI, compressed sensing, which are cutting down, the breath holding time, for instance? Would you be more focused on that part, like optimizing the scan from a technology perspective, or do you think that key component of patient preparation, communication, will always be crucial in cardiac MRI?
I think that communication and patient preparation is the most important thing in cardiac MRI. Just a little bit of coaching about how, as we spoke about before we started, if I ask you to hold your breath, you'll breathe in and you'll hold your breath. And that's how everybody holds their breath. Whereas in cardiac, we want to breathe in, breathe out and hold their breath. And it's completely alien to people.
It's
and
counterintuitive, right?
So it's counterintuitive. And if you explain to someone why you're asking them to do that, because it's more reproducible, because you're more likely to do the same every time, so the position of the heart doesn't move so much, then they understand and they'll try a little bit harder.
They cooperate
So it's
more
not
with you.
assuming that people won't understand what you're talking about. They're not going to. You can't go into extreme detail about. I mean, we've all had the question. So how does MRI work? The patient just as they're leaving. So how does MRI work? And machine go bang bang, make pictures. It's kind of the level that because you can't go into a full physics deal. So which part of MRI, which sequence do you want to know? That kind of thing. But there still has to be a level of information and a level of discussion between the patient and the radiographer. And again, a skilled radiographer, an experienced radiographer will know what level of information and what level of content that is appropriate for that patient, what's not going to make them nervous, what's going to make them more able to follow instructions. And it might be that their ability to follow instructions is impaired because they're nervous, they're claustrophobic, they've got something wrong with their heart and they're in hospital to find out, if they have heart failure. These are stressful.
Of course, yeah.
And these are stressful times for patients.
I was
having a stress exam as well. It's like you have angina, you have chest pain. we're gonna replicate that while you're lying down in a claustrophobic environment. We're going to give you that chest pain. We're going to try and replicate that,
explain that
and
to
then
a patient.
tell you to hold your breath while we're doing
or
it.
explain to an elderly patient as well.
Well, they're scared about the results as well.
Exactly. So it's about that report. It's about that conversation. And
I
it's
was
about
watching
building it up.
a podcast today, and Simon Sinek, he was saying that AI now write books for you, right?
Yeah.
And it's not about buying that book as a consumer. It's about knowing what went into doing that book. And it's exactly what we're talking about here. Yeah. It's not just getting that scan done with AI. Yeah. It's about the patient journey. Why is there? What is he complaining about? Why is he nervous or claustrophobic? Yeah. All of that information that we don't get with AI, I think is extremely important. That humanity
also this sits very well with the concerns from all the radiographers. Oh, AI is going to replace my current tasks and everything. It might change in a way, but this key components, communication, patient care, it's going to be there.
But AI, has many manifestations, and I think within cardiac MRI, it is an important tool. It is something that we use. So we've got our Easy Plan coming out. We've got Vitaline. We've got new products, and every vendor will have their new products coming out for cardiac, which are more reliant on AI than they were before. But these are tools. These are tools that have to be manipulated and have to be employed by someone who knows what they're doing. Our Easy Plan sequence is a 3D volume that you can plan all of your sequences from, which you can, but they still need to be checked. You still need to check that you have multi-phase. You still need to make sure you have end diastole and end systole covered. There still needs to be an element of image evaluation. So it comes back down to actually, rather than de-skilling our radiographers, our CMR radiographers, we're giving them additional skills. We're giving them better tools to evaluate what they're doing.
It's more about that. Sam Altman from OpenAI was actually saying that we don't see AI coming in our lives, but our lives will be completely different in 5 years because of AI. So it's getting embedded in every single thing that we do in our phones, in the way we work.
Absolutely.
It's creeping in slowly, and we using it because it's helpful.
It's an old used phrase, and I'm paraphrasing slightly, but AI won't replace radiographers, radiologists, cardiologists, but those who can use it will replace those who can't. And that's the thing.
To the point that I think the discussion about replacing is a little bit, old-fashioned at this stage. It's more accepting that the job is just going to change. Yeah. We're not talking about replacing. We're talking about, adjusting on the way, assuming this technology is going to be there for long term.
It's ownership of your
profession. But it has done anyway. If you look at when DR came in and replaced, standard X-rays, when we got rid of the dark rooms, it was like, we haven't got a dark room now, so we're not going to, how, radiographers are going to de-skill. And it's like, you have heard any radiographer that's been working for more than 15 years ago, they don't know how to set their KV and their MAS anymore. Exactly.
I think the skills of a radiographer are so transferable that with the new tools that we have, we're going to transfer those skills into something different. That's what you were saying. I think the profession is evolving at such a fast pace that we're taking ownership of our profession, and there are so many pathways of careers that we can take nowadays, and we can use AI as a tool to facilitate those pathways.
Yeah. But it's you have to understand the tool, and you have to understand how to check it as well. So basic example of that, within cardiac MRI post-processing, you'll have auto contouring. So as we said, as I said, you draw a lot of circles when you start. So this is all AI generated now. Now, if you've never drawn those circles, or you're not aware of what the circles represent or why they're there, how do you then assess the AI? How do you then check the AI if you don't know? Because it's during the mid-ventricular slices are very easy because they're circles, but when you get towards the apex, when you get particularly towards the mitral valve, then you have a little bit more subjectivity to it, and the AI struggles with it. The AI struggles with the things that you struggle with as well. So, if you have someone with a mitral valve replacement, it's hard to contour.
We're doing AI based on what we are as well as humans.
Yeah,
exactly.
Of course, it struggles. It trains on our
I mean, they have thousands and thousands of studies that they're informed upon. The algorithms are informed upon,
and they take the good and the bad.
But they still, a lot of those, because the UK Biobank is a big resource for a lot of these companies to do the training from. But a lot of the stuff in the UK Biobank is normal. They're normal studies, or it's very hard to get a good number of congenital studies to train an
To
algorithm
train an
from.
algorithm, yeah.
Because they're all different. And that's the thing with cardiac is the anatomy is roughly the same, hopefully. But there are huge differences from one to the other. And one of the things I talk about, is you can have 5 normal studies, but there'll be huge discrepancies within it.
I'm
There'll be
thinking about the
huge things
patient,
with different-
it's situs inversus,
Yeah,
like
exactly.
if the patient has the heart at the right
anatomy is
side.
the same, it's
Yeah,
on
the
the other
anatomy is the
side.
same.
Yeah, it's
so
just moved.
AI
It's
will a little
swapped
bit,
over.
what am I doing right now?
Yeah, and it can be it's challenging, and I think that's why when people start with CMR as radiographers, that they can struggle with it because,
Yeah.
again, as I said earlier, when you scan a knee, when you've planned it, or you scan a head, when you've planned it, it comes out, and you know what it looks like because it always looks the same. You'll see pathology there, but it's pathology on a plane that you're familiar with.
Yeah, the normal is always the normal.
Yeah. Whereas with cardiac, the normal can look
Different, very
nothing
different.
like what you're expecting in a book. So again, it's this image evaluation, teaching radiographers, giving them the tools that if your 4-chamber comes out and it doesn't look right, why doesn't it look right?
Yeah.
What's the anatomy? What am I looking at here that what can I see that I don't want to see, or what can I not see that I want to see? It's just as simple as that. And if I can't see something that I want to see, how do I see it? What do I need? What other views do I need to give me the extra information to get what I need?
Very open-minded.
And that then becomes less about protocol following, which is what the AI will do, and more about actual live interpretation and working out an image evaluation, which is then a skill. And that's something that, again, where I think that cardiac MRI radiographers will start to specialize in a different way. It's not going to be about setting up a viability scan, because the AI will be able to do that, and it will be doing that in a few years probably without any difficulty whatsoever. It's about when the anatomy is different, when there is a cardiomyopathy that's unexpected, when there is an extra cardiac finding, when the patient is struggling. That's when your skills will come in. So you'll still have to be aware of how to do the basics, even though the AI is doing it, because you'll have to repair it. You'll have to react to it, and you'll have to do something better.
You have to say, yeah.
So I think that's how our roles will change. I think we'll become more specialist, not less specialist.
It's perfect.
At least that's what I hope.
I think that's the perfect ending
Yeah.
for the episode. It's been an hour already.
Oh, wow.
Time flies when we talk about what we like. So thank you so much, Kevin. It's
Absolutely
a
well.
pleasure.
It's been a pleasure.
We'll ask you to leave us a small note about your experience
Of
today.
course.
Well, we didn't ask the final question,
Oh, yeah, we
but
need the
I
final
have to
question.
say, I mean,
You can go this time.
Go ahead.
no, I mean, there is this final question we usually ask for everyone, which for you I think is pretty clear, because I
Yeah.
think you
That's
definitely
probably why
very
I
good
skipped
in transmitting your passion. But we usually ask everyone, the guests particularly, why MRI for you? And I would say for you would be more appropriate why CMR for you, or why reporting, but why MRI for you?
So why CMR is it always changes. It's different every single day, and it's a little bit what I alluded to every day. Every day is a school day, and that's genuinely true. You will learn something from every situation you're in, for every environment, for every patient you scan, you'll see something slightly different, and it builds up that. And it's the differences, it's the constant evolution.
This constant learning curve.
Yeah,
always
absolutely.
learning
The
something.
Absolutely.
nuances that we have.
Yeah.
Perfect.
Perfect.
Thank you so much once again.
Thank you, Kevin.
Appreciate
Thank
it.
you
You're
so
very
much.
welcome. You're very welcome.
Thank you so much.
I'll grab you.